Good afternoon, everybody. Welcome to this month's Health Policy Grand Rounds at the Philip R. Lee Institute for Health Policy Studies. We are very excited today to have David Auerbach with us. David is a health economist and is currently the Senior Director for Research and Cost Trends at the Massachusetts Health Policy Commission. His team analyzes data from the state's all-payer claims database, hospital discharge data, survey data, and other sources to understand and report on salient and policy relevant trends and cost drivers in Massachusetts, and to make recommendations to reduce the cost of healthcare in the state. Of course, this is really notable work given that Massachusetts was very innovative and was the groundbreaker for establishing a statewide health insurance program that was really the model for the Affordable Care Act. Prior to working at the Health Policy Commission, David was a senior policy researcher at the Rand Corporation in Boston. And prior to that, he was a principal analyst at the Congressional Budget Office in Washington, D.C., where he co-developed the model used to analyze the Affordable Care Act. He is also a national expert on the nursing workforce and an honorary fellow of the American Academy of Nursing. He has a PhD in health policy from Harvard University and a bachelor's degree from the Massachusetts Institute of Technology. In full disclosure, the Institute for Health Policy Studies is a consultant to the Health Policy Commission through a contract that was established with the commission to provide some guidance and technical assistance regarding studies that they have done that are health workforce related. So with that full disclosure in place, I do want to introduce David, who will be opening up his camera. And it is wonderful to have you. I wish it were in person, but someday we will get to do that again. But fortunately, the presence of Zoom has enabled us to have presenters in who otherwise might be hard to get on their calendars. So I'm glad to have you here. I will share the screen and try to anticipate when you need to have your slides advanced.
Great, thank you. And I'll try to let you know as well so you don't have to guess too much. Hello, everyone. Yes, I am David Auerbach, and I am, as Joanne said, the Director of Research at the Massachusetts Health Policy Commission, and I also do a lot of work on the healthcare workforce, the nursing workforce especially, and that's how I know Joanne from lots of other different venues and past lives, but here we are. And I do appreciate the opportunity to present. And I wish that I could be out there. Fortunately, it looks like we're just coming down from our Omicron wave. I think that might be a little bit true in California also, but yeah, it's been a challenge for everyone. Okay, so today I'm gonna talk about controlling spending in Massachusetts, and from the perspective of the Health Policy Commission, and I'll tell you a little bit about who we are in the beginning. On the next slide, I have just a little outline agenda for what I'm going to talk about today. And I hope I'm not quite sure the setup with asking questions, but I'm certainly open to questions at any point, or if you save them to the end, that's fine too. So I'll give you a little background of who we are and what we're all about. And then, sorry, just stay there for 1 second and talk about some of what I might call our early successes, and then bring us more up to date as to what's been happening lately and why we're having some difficulty in the last few years, and what a little bit about what I think we need and what hopefully could happen in the future, but hopefully leaving a lot of time for discussion. And I'm sure a lot of the things that we are seeing are the same as what's happening across the country. I hear a lot about California from Glenn Melnick as well. I don't know if some of you know him, but he's a great colleague as well. Okay, so let's go into it. So this is a little bit of the origin story. It's a clumsy graph, but for what caused the Health Policy Commission to come into being. What I'm showing is annual growth in total healthcare spending in Massachusetts in the orange against the US in the blue. And whenever I look at this, I'm always struck by just how high that is, 6, 7, 8% a year in the early 2000s. As bad as things might seem today, or good, whatever your perspective is, we're nowhere near that. But in any case, you see the orange quite above the blue. And through that accumulation of years, and then on the next slide, you can see where that led us with that higher growth year over year. By 2009, we were #1 in healthcare spending per person. And you can see us there, Massachusetts on the left, by quite a bit, about 36% over the national average in terms of per capita health spending. And then, of course, we all know we are already a high healthcare spending country compared to everybody else. So the situation seemed quite dire. Okay, and then on the next slide, after a bunch of things, and you might also know that we did establish Romney Care at the end of 2006, which was kind of the precursor to the Affordable Care Act, and that probably did boost spending a bit in 07, 08, with additional people being insured, but that's not all that was going on at all. So by 2012, we had this high healthcare spending, and the state, Governor Deval Patrick and the legislature got together and said, all right, let's do something about that. They created an act. They created a healthcare cost growth benchmark, which was a goal, a target to keep healthcare spending growth to this benchmark, which is related to potential productivity, income growth, GSP in the state. So to try to keep healthcare spending to be in line with income growth and not continue to take a larger and larger share of people's total income. And the vision is a better healthcare system, a more transparent, innovative system with lower costs and without harming quality. In fact, improving quality where we can. So we set this target and created my agency. So you see there we are on the left, the Massachusetts HPC. We right now have about 55 employees. We're governed by an 11-member board I'll show you in a minute. We set the healthcare cost growth benchmark. We enforce performance against the benchmark. I'll talk about that. We have a certification program for ACOs and patient-centered medical homes. We collect all kinds of pretty cool data on all the provider organizations in the state, so we know who's with who. We do a lot in the world of antitrust and mergers. We have an annual hearing where we discuss what's going on and show a lot of data. My team produces this annual cost trends report, and we have money and grants for innovative care delivery. And we work hand in hand with what we call CHIA, the Center for Health Information Analysis. We couldn't do our job without them, and they existed prior in a different reincarnation, but we are the policy agency that was separated from what had been one large agency. They collect the data. They collect amazing data, the all-payer claims database. They get aggregate data from the payers, so we know what's going on with total spending. They collect all ED visits, all hospital visits from the hospitals, and we have that at a very, very good, a very small amount of lag. And we use all those sources as well as surveys, and I'll be showing some data in this presentation from a number of their different sources. Okay, next slide. Here is where our board members come from and how we're, the overseers of the HPC. Some are appointed by governor, by the attorney general, by the state auditor. Some of you might know Dr. Stuart Altman, who is the chair of our commission right now, and David Seltz is the executive director of the staff. Okay. And so a little bit about the benchmark, as I was mentioning, potential gross state product is what we're targeting when we set this cost growth benchmark. It was 3.6% for the first 5 years that was set in statute. Now we're in this in-between period where we've had the discretion to set it anywhere between 3.6 and 3.1% growth. Every year, the legislature and the board have voted to have it be as low as possible at that 3.1. And just next year, it's going to get really fun where we can set that really anywhere at all. And I don't know what's going to happen, but right now it's 3.1. Okay. Next slide. And just another kind of overview slide of how we do what we do. Some of those goals that I showed you before. It can be divided into a number of broad functions. We are a watchdog agency. We bring people together as a convener, research and report. A lot of what my team does. We partner with organizations to try to achieve all of these goals. Okay, next slide. So now I'm showing you the full slide that I covered half of before. And it looks pretty impressive, probably a little better than it really is, but you can see that starting around 2010, really, even though we were created in 2012, this growth story has flipped, and the orange has been below the blue every year since 2010. So we have been growing more slowly than the rest of the country since 2010. And on the next slide, I'm showing the same thing, but in the commercial market, which is really where we have most of our focus. And that is because most of the policy levers available to us really most of our attention is on the commercial market. We don't have that much influence over Medicare policy. And with regard to Medicaid, what we call mass health, there is that Medicaid policy mostly takes place within the executive branch, which is really whole separate agency, whole separate policy-making entity with their own data collection and analysis. So we really spend most of our time thinking about the commercial market. And you can see if you look at premiums in the MEPS, for example, up until we were created, our premiums grew 50% from 2005 to 2012, faster than the US. Since then, we've grown 25% versus 32%. And you can calculate, if we had grown at that rate, or how much did we, quote, save, and so on. And so, it's hard to perfectly attribute. Is this because of our existence? Is it because all of the stuff that we've done? And it's probably not all of it, but probably some of it. There is probably somewhat of a, regression to the mean or compensating for prior past growth. I don't know. But we often hear stories like insurers would sit down as they negotiate with hospitals or providers and would often say, well, you're asking for a 5% rate increase, but I can't give you that. I'm going to get in trouble with the HPC. And it would provide some additional backing in that negotiation to get those prices down and to help the negotiations towards lower and so on. So that's probably one mechanism that has been at work, and we hear that, kind of in the back room. Okay, next slide. So yes, great. We're no longer the highest cost state for healthcare. I think at the last I saw, we're maybe number 2 or 3. We're all waiting for the new CMS they put out the state data in 5-year chunks, and they should be putting out 15 to 19 pretty soon. We were able to prevent several hospital mergers that had been proposed. That probably helped somewhat. We certainly had a hand in fostering and the spread of ACOs and risk contracts and alternative payments, although I'm not sure how much that has really done. And of course, I can pat myself on the back and say we certainly understand what's going on a lot more than we did before the HPC existed. So all these things help. And that understanding, this is still true. Even though I'm going to show you some of the problems, that understanding does flow into the legislative process pretty directly. They use our recommendations, our data, our thoughts all the time as they think about what do we need to do. Okay, but let's move on. So now I'm bringing you up to date, and now we're into the problems side of the story. This is showing growth compared to the benchmark, and this is each of the years that we've been in existence so far. And you can see that orange dotted line is the benchmark was 3.6% for a while, and then it steps down to 3.1%. And so you can see our growth year after year. Some of that 2013, 14, 15 was directly attributed to Sovaldi and other high-cost drugs that came onto the market. There was the ACA Medicaid expansion did still have some impact here, even though we had expanded, the ACA expanded Medicaid further. And some of that growth was because of that. But you can see in 2017, 18, 19, we have blown through our target and exceeded it quite a bit. So what's going on? Okay, let's continue. This is just another visual or comparison that I like to help people understand what's really happening with healthcare and why we should care. But the orange is showing total family health insurance premiums. And sometimes it's incredible to me that they were actually so low. even in the year 2000, $7,000 a year for a family. And now we're up 22, 23,000, tripled. And the cost of other things like a compact car has really not changed in this time. It used to be 3 times as much as your annual health insurance. Now it's actually less. And we compute other statistics such as the share of middle-class commercially insured families who are paying more than a quarter of all their earnings to healthcare. That has grown. It's up to a third in 2016 to 18, and that's really quite a lot. And as you know, so much of it is invisible to folks. It just gets, pulled from their salary, the employer contribution to their premium, even the employee. Most people really don't know what's going on. And it's just kind of automatic, and it ends up as wages that they never get in the first place. Okay, next slide. We also see over the last few years a lot of growth in high deductible plans. People hate high deductible plans. You can see it differs by market size. If you're in the small group market, 2/3 of folks are in a high deductible plan. And this is really a response that employers and insurers are making to these growing underlying costs of care. Nobody likes having high deductible plans, but everyone's desperate to try to keep that premium growth as low as they can. And this is often the go-to way, and this causes a lot of other problems. Next slide. This is another calculation or construct that we did to help people think about how much money was going to healthcare, where it was often just, as I've said, not salient. But we could look between 2016 and 18 and calculate based on people's income increase and then how much premiums grew over those 2 years, and actually found that more of people's earnings growth over those 2 years went to healthcare than went in their pockets to take home to spend on everything else. Almost 40 cents on the dollar was absorbed by just higher healthcare spending. Okay, next slide. Here, when you compare against people's growth in wages and salaries or inflation, the cost sharing, the premiums are all growing faster. And this is counter to the whole idea of the benchmark and why we came into being. Okay. So why is this happening? What do we think is going on? So now I'll show you some of what we have learned as for the underlying reasons. And again, I think it's probably fairly similar stories across the country. First of all, we can break down that spending growth by category of spending. You see hospital inpatient up there, hospital outpatient. We're showing growth over those last 3 years. And hospital outpatient growth really popped up in 2018-19. Physician and professional spending is growing pretty fast. The pharmacy is a problem, although not as high growth in these past few years. And that is when we take out rebates. So that does not mean to minimize that problem, and we're working on that separately, but it is a big deal. Okay, next slide. But really, most things tend to point to the hospital, and that's what I'll show you. We also look at where people are going to the hospital, and we could sometimes conveniently divide our hospitals into these bins or categories. We have a lot of academic medical centers in Massachusetts, and you can see those on the top in that blue line. And if you count all hospital outpatient visits by which type of hospital, you see in the orange there, those are our community hospitals that have a high proportion of Medicare, Medicaid. So they're called high public payer hospitals. There are the most of those, but in fact, the AMCs, the famous Mass General, Brigham and Women's, and so on, they are increasing their share of all volume, and they have higher prices. And when their share of all volume grows, especially at the expense of the other hospitals, that also will tend to make prices higher because you're paying more when you go there. Okay, next slide. And here's just another slide of something that we do when we look at this hospital outpatient spending. Why is that a concern in some cases? You'll often have the same exact services that could be provided in a physician office or a clinic or a lab or in a hospital outpatient department. And they are pretty much everywhere more expensive when they're done in that hospital outpatient department. Even just a simple lab tests like I'm showing here, often twice as much when they're done in that HOPD. And that volume is about half. As you see below the graphs, there's little volume circles showing that we are doing most of these simple labs in a very high cost place. Okay, next slide. And so now to understand more about what's driving these trends in commercial spending, this is just showing national data for a minute. And you see private health insurance spending pulling away from Medicare, Medicaid trends. And the reason for that is that it's the prices. That's the one difference between private health insurance and Medicare, Medicaid is that the prices are uncontrolled, they're not set, they're negotiated. And to put it in a nutshell, the hospitals are winning. You can see price growth by different categories of care. The hospital inpatient price growth from 15 to 19 was 30%, 22% for hospital outpatient, and so on, higher than in other sectors. Next slide. And that national story is true in Massachusetts. When we break down price growth for our largest insurers, you see that that the growth in prices explains twice as much of the growth as the growth in utilization does. And the Healthcare Cost Institute finds the same thing. They do this for every state, and as you could look it up for California. They found that prices grew 15.5% for this bunch of years, while utilization grew 7%. So it's 2 to 1, it's about the prices. And when you look a little further in Massachusetts, it's mostly the hospital prices. Okay, next slide. Another way that I find helpful to think about hospital spending is prices can be complicated. We spend a lot of time thinking about prices. You have severity, you have shifts in the kinds of care, but if you just really step back and think about how much am I spending per discharge, per hospital stay, that number has been growing 5.5% per year in Massachusetts. Over this period from 2013 to 19, price of a hospital stay grew from 15,000 to 20,000. And you can see in the blue, even just tallying up total spending, grew from 3.8 billion to 4.6, and actual volume of hospital discharges is dropping over this period. It dropped quite a lot in the yellow from 13 to 17. And so even as that volume is going down, you're spending more. And that 5.5% is a combination of growth in the price for a specific, per DRG severity, and a growth in coded severity, which I'll talk about in a minute. They're both contributing there. Okay. And our favorite, we all know about price variation. Price variation is quite high. This is outpatient prices. This is done by the RAND Corporation, not by us. They took some private health insurance, private companies, took all of their claims, run it through what would Medicare have paid for this, and what did they actually pay for this? And you can see by hospital, a couple of our hospitals are up 3 times what Medicare would have paid, but the range is about 3 to 1 across this graph. And so if volume shifts from that lower price hospital to the higher price hospital, you end up paying more as a state. Next slide. Here we are showing, as reported by the payers, rolled up total spending growth divided into how much is accounted for by price, how much is accounted for by utilization. So I showed this before, but I want to show you even 2020, we have this data now, and the prices increased even faster in 2020, even while utilization, as we all know, fell off a cliff. And so 2020 spending, at least this is in the commercial market, we expect to be slightly down in 2020, and that's what CMS is basically finding as well. But when utilization comes back, as it is now in 2021, 2022, it's hitting those high prices, and I imagine prices did not stop growing in 2021 either. Okay, next slide. And so I'll talk for a minute about our main accountability mechanisms. What can we do about this, and why they are not as effective as they should be? And so going back to this concept of the benchmark, this 3.6, 3.1, how do we enforce that? What kind of teeth do we have to put that into play? Well, here's the main way we can enforce that. So what CHIA is doing is every year it's collecting data on total spending for every, think of a unit that I can attribute a member to this PCP group. Take the collection of all of those patients, and we do some of this for PPO when you can attribute. Take all those patients and just ask how much did spending across those patients for, large provider group X grow from year to year. So we have this concept called health status adjusted total medical expenses, and this is all across the board, everything you're spending on, everything at least that the insurer knows. So don't count like over the counter or out of network, but take all that spending and just say, how much did that grow from year to year? And if that growth is higher than the benchmark, then you get put on the naughty list in a sense and sent from TIA to the HPC. And then we look at all of the both payers and payer provider pairs, okay, on the naughty list. And then we decide, well, did this happen because of some factor outside of your control, like Sovaldi, or no, we really can't let you off the hook. It looks like your growth was too high, it was in violation, and we can then go through this process called a performance improvement plan, or a PIP as it's noted here, and then say, okay, we have to vote on this, and then you have to do better, or else you'll be fined in the next year. And that's how the process works. But there's a key problem that has played out with this process, and you'll see it's what we are calling HSA-TME. It's not literally the total spending growth for those members that we are tracking, but it's the risk-adjusted spending growth, or the health status adjusted spending growth. And where they report, well, here's my total spending growth, but here it is when I apply my risk adjuster, me, the payer, whatever I use. And that's what is actually the trigger for this process. Okay, next page. And the problem is those risk scores have been growing through the roof. You can see here we're tracking the risk scores by payer in the state for a number of years, and it's just growing. And we have done everything we can do in the world to try to figure out, if you just saw this, you would think, oh my God, the whole state is just getting sicker and sicker every year. We're just going to hell in a handbasket. And it's not true. It's not true by any stretch of the means. And the more we look closely at this and what's going on, it's a national phenomenon that's happening everywhere. People are getting better at coding because because it pays to do more coding, and that's what's happening. And when that happens, our risk scores are growing 2% per year. Well, I'll show you the consequence of that. 2 to 3% per year. Sorry, before I get to the consequence, just another example of how we know this. This is showing all hospital discharges in the state categorized by the severity level using the APR-DRG categorization scheme. And this is how most commercial payers pay. Medicare pays on a similar kind of scheme. And you can see severity level 1 in the blue, 2013 through 2020. That is just becoming a smaller and smaller and smaller portion. And severity level 4 on the top is more than doubled in the relative proportion of severity 4s. And it's just a smooth period. This is the hospitals doing this. Everybody's doing this. Everybody is coding. These are not sicker patients. Okay. And so what does that mean? Here you can see from 13 to 19, total spending growth in the state, 23%. But the risk score growth was 15%. So that means that your risk-adjusted spending growth is only the 7.6. So 2/3 of that spending growth essentially gets deducted or gets offset by the risk score growth. And then the next slide, just to show in real concrete terms what this means for our program, is I just picked like 9 random payer provider pairs. And if you look at their growth before risk adjustment in that left slot, you can see some of them had growth that was 5%, 6%, 10%. But then when you deduct their risk score growth, all of them but one then fell below that benchmark, whereas most of them would have been on our naughty list before, risk adjust, and now they're mostly off the list. And we never see them, or we're not allowed to see them. So that is a major problem that has put a big dent in our main enforcement mechanism. And we are trying to get that fixed. Okay, so let me see where we are in time. Okay. Should I try to accelerate, Joanne, or keep going? Because I now have just some more sections talking about the problems of healthcare spending and high prices for affordability, for what does this actually cause for residents in the population?
I think we're doing good on time, and I will invite anybody who is here, please put in any questions into the Q&A box. And if we start having a stack up of questions, then I will either jump in, David, and bring them to you immediately, or I
Yep.
will kind of nudge you to go a little bit faster. But I think your pacing's okay so far.
Okay, sounds great. All right, so transition to a related but new section. This is some work that we've done on my team to try to understand and show. Okay, I just talked a lot about prices, about healthcare spending growth. What does this really mean? How does this affect regular people, people day to day who are, especially in the commercial market, buying insurance, paying premiums, going about our lives? And the overall point is that this is all connected. These high and rising prices lead to higher premiums, higher deductible plans, more out-of-pocket costs as people try to escape that premium growth. And these lead to inequities, worse health, and worse financial outcomes. Okay, let's go on. So now for a number of slides, I'm drawing on a survey, an annual survey, like California's health insurance survey. We have a Massachusetts health insurance survey that CHIA conducts every 2 years, a sample of around 6,000 residents. And they tell us about stuff. And I can divide the commercial population into those below 400% of the poverty level and those above. Those below I want to focus on, and that's in the blue. And you can see, of course, they're facing more of these affordability. They report more of these affordability issues. But the absolute numbers here are high. Medical bills being paid over time, more than a quarter. Problems paying family medical bills, high share of family income spent out of pocket. Unmet needs are quite high, more than a third. And any of the 4 affordability issues is more than half of the population with commercial coverage that are below 400 FPL. Okay. We then focused in a bit on the folks reporting problems paying medical bills. What kinds of medical bills are leading to these problems? So here you have this 21% who said, yes, I have problems paying my medical bills, and it's from all kinds of routine services across the board. Medical tests and surgical procedures really bumped up as one of the highest. Ongoing treatment, emergency care, dental care, drugs, everything. Next slide. And then focusing on people who went without care because of cost, these unmet needs, 31% of the lower income folks. And it's, again, for all kinds of basic care, doctor, specialist, prescription care that I'm going without, dental and vision care that I'm going without, and of course, more in the lower income population. Next slide. We see these problems are greater, about twice as high among folks with high deductible health plans. Whether you're low income or high income, it's about a factor of 2. And again, it's not surprising, but it's really going back to this out of pocket that people would face, and they interact with the healthcare system. This happens, they know it, and they avoid healthcare the next time around because of that. They can't afford it. And we do see even disparities by race and ethnicity in that. Next slide. As we asked more about this, about why people are avoiding necessary care, half say it's because the copay or the coinsurance was too high, and a pretty high number said that I'm not even sure if specialist care would be covered. It kind of goes back to just some of the out-of-network problems that hopefully are a little better with the No Surprises Act, but the confusion of health insurance and just people not knowing what's going to be covered and if they're going to be faced with a big bill. And quite a few people said, even though if I had a problem that could have been treated at an urgent care center, well, I'll still go to the ED. At least I know that's going to be covered. We also see a high proportion of folks, 55% of low-income folks, saying they did get an unexpected medical bill in the last 12 months. And this really does have an impact. Next slide. And one of those impacts is also, as I noted, on the ED. In this upper left quadrant, if you group people by those who said, I went without healthcare because of cost, and I have low income, and then ask them, was your last ED visit probably something you didn't need to go to the ED for? And 2/3 of them said yes. They actually said, yes, that's true. And it's especially with that group. It's these accumulated health needs that they're going without. It's lack of access to care. It's being afraid of the out-of-pocket cost. Okay, next slide. So that's the end of that set. And this leads to, as part of our annual report and our public hearings that we make a number of recommendations. And we have had some success in having some of these recommendations then followed through on legislation that comes out. And something that for the first time that we recommended this year was a direct constraint on provider prices. We have just found through all of the evidence we've compiled and everything we know over the last 8 years, we have pushed limited and tiered network plans. We've pushed alternative payment mechanisms and ACOs, price transparency, which is better now than it used to be, preventing mergers from happening, all of this set of stuff, and trying to make the market as competitive as possible. We and many of the other health economists of the world have just found that it's not enough. It's just not a competitive market that's going to work in the way that we hope. Hospitals just have, in general, market power over insurers, and they have a lot of ability to continue to raise prices. The insurers can't say no in these negotiations, especially the must-have anchor academic medical centers. They just have a lot of pricing power. So we recommended caps, and we weren't very specific yet. There's a lot of work to go into this, but you can talk about caps on the level of prices that an insurer is allowed to pay for a given service, maybe some percentage of Medicare, or the growth in prices. And we've been talking about both. Okay, yeah, you can go to the next slide. And we have also recommended, which I feel good about getting this, perhaps having some ability to influence this, is fixing that risk adjustment problem in that formula for who gets referred to us for a performance improvement plan, as well as other issues. As I mentioned, the performance improvement plan process is really focused on, and it makes sense, it's focused on total healthcare spending for people that have their primary care with that primary care group. But at the same time, what happens is, if I have my primary care with provider group X, they're often going to see a lot of hospitals. Hospitals aren't directly implicated by this process, although a lot of the hospital systems also have primary care physicians and have their own PCPs and system, that's fine. But there's not a one-to-one fidelity between primary care group and what hospital they go to. So it's a little bit indirect. So we also have talked about, the price cap or a price mechanism could directly constrain the hospitals to some extent. But we also have asked for a broadening of this mechanism. Okay. Let's see. Okay, that's really the end of the main part. And I have a number of things towards the end if questions come up. We've spent some time talking about COVID, and if people want to talk about that, I have some additional slides. I have a slide or two on the nursing workforce, and I'm sure, as everywhere, we are really having staffing challenges. I think we're down about 700 staffed beds from what we were a year ago, and it's because we can't find the nurses. It's because we can't staff them. So our hospital capacity is having a real problem that is not primarily because of COVID, although of course COVID is not helping, but there's a number of things. But at the end of the day, our hospitals are also, their margins are back, and if not better than they were pre-COVID. So I'll just pause there. Were there any questions that came up in the chat, or spontaneous questions would be great?
Yeah, we have some questions in. I'll give the first question to Sarah Garrett, who is one of our postdoctoral fellows. And she said, she observed that you shared a lot of engaging graphics to represent your data. Your charts are interesting, and you had other graphical devices for presenting data. Could you talk a little bit about how you approach scientific communication and advice that you have for other scientists who want to communicate better with the public, especially for policy-oriented things like this that maybe have some controversy among some of the constituents you regulate?
Yeah, that's a great question. I've never been asked that, and I appreciate it. Number one, my advice is to get a graphics department, and we do have but that's not very practical. We have a group that we've really spent a lot of focus on that, maybe because we're a new agency and wanted our message to get across to, to the policy community, to the legislators, and to the public. And we've always had a dedicated person, maybe 1.5 folks now in our agency of 60 people, who are graphic artists. And we work with them directly, and we now have a great relationship where we will, on our team, on the research team, spend some time thinking about what is the best sort of graph to depict this phenomenon that we're talking about. So that's something you don't need a graphics art department for, but really thinking carefully about what is the point I want to make and what is the best way to show it. Is this do I want a bar graph? Do I want a line graph? Do I want basic stuff that people often don't think as much about as they should? Then we send the data over to that department in simple Excel spreadsheets and say, work your magic, and they do. And it's an iterative process. They'll say, how's this? And they'll create something, send it back as a PNG, we'll make comments. And so that's really how we do it. But I find that it's easier for me to say, not everybody can have that, but that effort is such a return on investment in terms of having people see and understand your work. And I really enjoy it. If anybody even wants to ask me or email me, I have this data, I have this trend. What do you think is the best way to show that? I would please feel free to ask.
Yeah, so I invite people to put questions in the Q&A box as part of this Zoom. So I have a question for you that I feel like there's a certain amount of Uwe Reinhardt saying it's the price is stupid, echoing through a lot of what you presented. And there are a few different things that came up that point to providers that you mentioned. One is the clear incentive to code more, make sure you don't miss any secondary diagnosis that might increase the acuity and therefore the payment you receive. And also that certain kinds of organizations like must-have academic medical centers have a lot more leverage in the negotiating process. I'm curious how that gets handled, because you all have a public process that you engage in where these organizations have opportunities to push back and to communicate back. And I'm kind of curious from both a evidence standpoint and a process standpoint, how the research that you all do and the approaches that you take can try to get this information out there and create actionable strategies around it, given the, pointing to the providers and saying, you guys are like, charging way too much. Does, one person's waste is another person's paycheck.
Yeah. Thank you. Yeah, it a bit gets into the politics, which it's hard to not talk about. It's there and it's everywhere. One of the most interesting things that we do, which is in the statute, is that every year we have what's called an annual cost trends hearing. It used to be a 2-day process, and we've condensed it for COVID times, but we often call it our Super Bowl of healthcare, and the governor speaks, the attorney general speaks. We have the ability to require testimony and data from all the insurers and all the hospitals. They have to answer questions that we send before the hearing. And then we use those answers, and our commissioners, we have them come up on a panel and they batter them with questions. And in 2012, when this act was passed, and I didn't start until 2014, but I have this sense that it was kind of a shared goal that everybody was agreeing to, that we are going to try to keep healthcare spending at this target. We're all going to work together and do what we can. And I also feel like in those early years, 2012, 13, 14, maybe there was a prevailing national trend where, healthcare cost growth was on the low side nationally. Maybe it wasn't so hard. Maybe it wasn't so hard to be all in the spirit of things. But that's what I feel like is eroding lately. And if you can watch this on YouTube, if you see some of the questions from this year's hearing just a few months ago with John Berwick and David Cutler and some of the commissioners asking the highest cost, the highest price systems, directly they'll say, look, your prices are significantly higher than everybody else. Do you plan on doing anything about that, or are you fine with that? And the answers would be sort of, around the bush, implying that they're fine with that. And I think that that's really what's happened, is that whatever it is, those revenue pressures for a lot of these groups just have outweighed whatever this shared commitment or goal might have been at the beginning, and has kind of led us to this path of, look, people aren't going to do this voluntarily. Nobody really wants to give away revenue voluntarily. And we're going to have something tougher politically if we want to make this happen. It's kind of where we've gotten to. There was an interesting proposal the Baker administration put forth a few years ago, which I'm not sure they're going to bring back, but it gets at this question of levels of prices, and I showed you the variation, and then growth in prices. And what they said at the time was, let's have a proposal where we'll say, if you are because whenever we talk about limiting growth, there's this problem where the hospitals that are kind of at the low end of the food chain, the struggling community hospitals that nobody pays very much, they say, well, if you're limiting everybody's growth by the same amount, I'm never going to catch up. I'm always going to be so far behind everybody else. And that's not fair. And so it's a hard problem. So what the administration floated was, let's say if you're a low-priced hospital, you can have unlimited growth. If you're a high-priced hospital, you're constrained and you can't grow at all. They contemplated putting them into tiers and having an allowable growth that was different based on how high you were starting. And that would ideally kind of squish the field. And it was kind of a neat idea. I'm not sure it's going to come back, but it's like you have to think creatively about levels of prices and about growth in prices to try to get the outcome you want. And I don't think any state has really done this yet, but Rhode Island does have a cap on price growth. And we've looked at that very closely, and researchers have too, and they found that really has worked. That really has led to lower hospital prices and lower premiums. And it's amazing that they did it back in 2010.
Yeah, two observations that I have on that. One is, Medicare, when it began its performance-based payment incentives, was aligning those with the amount that a hospital improved or whether they were already in a top rating, and they would be eligible for those payments, with the idea of, if you're already one of the top rated quality hospitals, how much more can you improve? And if you're low and you come up, then you should also get a bonus. And it's almost like the converse of what you just described from a policy standpoint. The other thing that I think is intriguing, the other thing that I think is intriguing is the names that you mentioned of who some of your commissioners are. It's very clear that the leadership that appoints those commissioners have a history of taking those commission roles very seriously. And those don't sound like people who are kind of handpicked to toe a particular party line, right? Which is also really intriguing about the kinds of conversations that you can have that are perhaps unusual in a lot of venues.
Maybe it is. And on that earlier slide, I showed that they're appointed, they're kind of divided up as to who gets to appoint them. And there's even more than that. There's kind of there's a provider slot where we have a nurse in there right now. I think there's actually a nurse slot and a physician slot. I'm a little bit unclear. There's an industry slot so they do try to have representation. There's an academic, several of them. Yeah, so they were pretty thoughtful about how those folks get picked, and I think it does work out fairly well.
Mm-hmm. Yeah, so you referred to some of the data infrastructure that your kind of partners in crime, CHIA, have put together over time. When this whole endeavor began, the commission began and so on, was there an all-payer claims database? Were there resources, or what things were built? Right now, I point that, I ask this because California has a new agency that basically is kind of the new OSHPD, or the Office of Statewide Health Planning and Development has now become the agency, is now a full freestanding agency for healthcare costs. Healthcare Access and Information, HCAI. And they have a data charge. There is a process underway about trying to create an all-payer claims database. What of that infrastructure existed as the, Romney Care was coming into play, as your commission came into play, and what came into place when it was clear that you all needed that information to do your work and became a clear charge to establish that? Because I think we're trying to set that up in advance as the Healthy California for All Commission is bringing recommendations forward and legislations in play.
Yeah, great, good question. Probably the single most important thing that we rely on that was in so many of the slides I showed was in place beforehand. And I don't know exactly how hard it is to do this from scratch, but the number one most important thing is the aggregate data reporting that CHIA gets from the payers. And it probably took I'm sure it took a lot of iterating with them to get them to be able to report this data the way we want it. But that's the key thing, is that almost everything we know is reported by the payers. And they are able to, a lot of this is stuff they do in their normal processes anyway. But they can look at a member and they have data on the member month, on their spending from all sources, and they can roll this up in a calendar year, and they can break up that spending by, they run some simple codes by category. This is hospital inpatients, it's just the aggregation of all of those claims into these gross categories that the payers send in after their claims run out. It's about maybe 9 months after the calendar year ends. CHIA collects this from each of the payers and then melds it together to figure out what total spending growth was for the state. And then all of that sub-reporting, like what we need for our performance improvement plans, it all comes from that. And this is, again, it's so important that we get this data in a fairly timely fashion, because the all-payer claims database, there's just going to be a lot more lag time in that. And if we had to rely on that, we wouldn't know what was going on in 2020 until 2023. And it's kind of too late to then punish somebody for what happened 3 years ago. So that payer reporting and all of the specs are somewhere in CHIA's website, if anybody wanted to try to imitate that and do something similar. And I don't think it's that hard now for the payers to do. We recently added on to them and said, now we want you to report primary care spending because we're going to potentially have some policy around that. But that's number one. The all-payer claims database was around for a while, but my guess is that it was mostly researchers using it, applying to CHIA, doing a deep dive for the research question on some narrow subset of the population. And what happened when we were created was that we wanted to use it in a different way. We wanted to be able to do some of the slides I showed you, to look at aggregate price trends, to look at what's going on with outpatient surgeries writ large. And so the problem we had to solve was how to take this massive, millions and millions of gigabytes of claims data and then be able to process it and use it and break it down. And we have tremendous researchers who know how to use SAS and Stata, and but we had to work with CHIA quite a bit to have them send us the data in the way that we need it. And for a while, we were then taking these flat files of a calendar year of all the claims data, shipping it off to a consultant, and you can imagine who some of these consultants might be, and spending hundreds of thousands of dollars for them to then send it back to us in like more easier to use, annual files. We have now finally cracked the nut of doing that on our own pretty much, but it's a lot of work. It's a lot of work to process all of these claims into a way that is useful. So I would say more important, well, they're both important. That let me show that graph where I was like, getting a lipid panel in a Hop D versus in a, $33 a pop. Anyway, those kinds of things. but most important is that total spending aggregate level data that would be great to get from the payers.
Great. Good guidance as California tries to tackle some of these universal health insurance ambitions and data infrastructure needs. We are just about at the top of the hour, and I don't see any other questions coming in. Thank you for spending the time to tell us about both the patterns that you see, which I think you're right, are probably similar to what you would find in a lot of other states, and also the process by which Massachusetts continues to be a leader in both ensuring health coverage for people and also recognizing that these things can be very high costs. So thank you very much for your time today. And if anybody wants to reach out to Dr. Auerbach another time, we can share his email address, and we will be keeping an eye on what the Health Policy Commission does in the future. Thank you so much.
Great. Thank you. I enjoyed it.